Thank you. Saloner. I was meant to ask you that because I've been practicing and I'm like, oh, I hope I don't pronounce it wrong. Thank you.
All right, we have some folks joining now. We'll just be starting in a minute or two.
Great. Pat, I wore my Hopkins blue today, just for you. So I think I'm ready whenever you're ready. Great. Well, welcome, and thank you so much for joining us during Johns Hopkins Alumni Weekend Goes Viral. This is the Hoptalk, a pandemic meets an epidemic, treating opioid addiction in the era of COVID-19. My name is Erica Youngst, and I'm the Director of Alumni Relations and Annual Giving at the Johns Hopkins Bloomberg School of Public Health. So along with the Reunion and Homecoming Office, I am truly delighted to bring this session to you today. We will be facilitating the Q&A session throughout the presentation, so please feel free to submit your questions. You'll be prompted to do so, but at any point you can please feel free to submit some questions using the Q&A button or the chat feature at the bottom of your screen. So we will get to as many of the questions as possible once the presentation is complete and throughout the conversation. Now it is my pleasure to introduce you to today's presenter. Dr. Brendan Saloner is an associate professor in the Department of Health Policy and Management in the Bloomberg School of Public Health. He also holds appointments in the Berman Institute of Bioethics and the Department of Mental Health, and is the co-leader of the Addiction and Overdose Working Group of the Bloomberg American Health Initiative. Dr. Saloner is interested in issues related to equity in the financing of health services for vulnerable populations and in issues related to healthcare reform in the United States. He also has empirical interests related to mental health and substance abuse treatment, children's health, and public insurance. His work has been featured in notable journals and also in the New York Times, NPR, CNN, and other major news networks, but most recently I saw an opinion piece discussing Medicaid during times of crisis, featured in The Hill. So we are indeed lucky to have you with us. So without further ado, welcome, Dr. Saloner.
Well, thank you so much for that introduction. It's really a pleasure to be joining you all in this virtual environment. And I will begin with the disclosure that you are joining me today from my basement bunker. I've got two little children upstairs who are hopefully going to start their nap soon, but you will know if we get any Zoom bombers where they come from. They're very sweet. So I'm going to go ahead and launch my presentation here. Just give me 1 second. Okay, I think I need to hit the screen share button. Sorry. Okay. How is that? Give me a thumbs up if that's okay. Okay, wonderful. Well, great. And I'm going to hope to do my best to make this an interactive presentation today. So I will from time to time actually solicit your questions, and you will know to then at that moment, please type in your questions. You will have a chat window in which to do that. So let me just distill for you what this talk is about. I mean, I think that we all understand the incredible and at times catastrophic circumstances that we are under. COVID-19 is certainly affecting all of us in some ways. But I want to really talk today about a population that was in not great shape before COVID-19, people with substance use issues, and particularly around the opioid crisis. And I will try to explain in my presentation today why this is a uniquely vulnerable population for a variety of reasons. And even though we don't have great public health data yet, we are seeing signs that COVID-19 will make the opioid crisis worse. I believe it has started already. And yet, and I hope to give you just a little glimmer of optimism, I also think there's some small opportunities to try to improve how we provide services for people with opioid use disorder. So with that, let me get into the 4 big questions that are on my mind. So first of all, we'll talk about what was happening in the opioid crisis before COVID-19 hit. I am not presupposing any particular expertise from you all, so if this is a new issue for you, do not worry. Second of all, I want to talk about how COVID-19 has changed the opioid crisis itself to the extent that we can know that. And then third, I want to discuss opportunities for better public health policy going forward. And fourth, just offer some concluding thoughts about what we might expect in the future. So before COVID-19, we had the opioid crisis. And I think it's fair to say that addiction, and particularly overdose, is the generational public health challenge. There's a lot of different ways to sort of understand the magnitude of this crisis. It's the leading cause of injury death in the United States. It now surpasses deaths from firearms and motor vehicles. And if you look back to the last 20 years, you actually can account for more than 500,000 Americans who have lost their lives from overdose. And that's more than all Americans who lost their lives in World War II, World War I, and the Vietnam War. It's a really staggering toll. And you know, one of the sort of the benchmarks that we all look to is life expectancy in the US. We actually know that life expectancy began to reverse in recent years. So it's either slowed down or reversed depending on what year you look at it. And we know also that drug overdose is a major reason for that. If you want to look at it kind of graphically, you can see the heat map of the US. Areas that show up darker in red are areas that have had higher burden of overdose. And you can see that around 2000, drug overdose was largely clustered in areas like Appalachia and in parts of the Southwest. If you then fast forward to 2015, and this heat map remains largely the same, you can see that virtually all parts of the country are now lighting up in dark red, meaning that this crisis has really affected virtually every corner of the US. And of course, for all the numbers that we see, each person who loses their life from overdose has their own story and you know, has a biography, and it can become numbing to think about kind of the enormity of this, but you know, it's important to just look at some of the lives. This is a picture that was produced by Stat News. So we often talk in public health about different waves of the opioid crisis. I think the one that the public is perhaps most aware of started back in really the 1980s with the rise of prescription opioid pain relievers like OxyContin, which came on the market in the 1990s. And basically what we know now, which we didn't totally know then, is that these drugs had incredible addictive potential. So a lot of people were prescribed them for an ailment, for a pain situation, and then subsequently became addicted to opioids. And so a lot of the overdose deaths, if you look back to the early 2000s, were attributable to prescription opioids. Moving a little bit forward in time to the mid 2000s, we see that there becomes a big increase in deaths related to heroin. So around 2010 is really when you see heroin in a major way contributing to opioid overdose deaths. And a lot of that heroin comes from new source countries like Mexico, and it's formulated a little differently. Then finally, in the more recent era, several years later, synthetic opioids, and especially an opioid called fentanyl, which is about 10 times more potent than heroin, starts mixing into the drug supply. And fentanyl is incredibly cheap to manufacture. Per dose, it's a lot more potent, as I said. And so fentanyl then becomes one of the most common, if not the most common, drug involved in a drug overdose. I actually do believe that we're now in a fourth wave of the opioid crisis, which is a polydrug epidemic. And we can talk more about that if we have time later in the presentation. And of course, we know that an overdose death is just the tip of the iceberg. So for every person who dies from an overdose, many more people go to the hospital because they non-fatally overdosed. They were admitted to the emergency department, and kind of beyond that, as many people who may just have problems that don't rise to the level of an overdose or a full-blown addiction. You know, we could talk if I was doing a different presentation, we could talk for a long time about the drivers of the opioid crisis. But to me, if I was really going to distill it, I would look at three big factors. One, which I've already mentioned, is that the drugs themselves are extremely potent. And not only are they potent, they're unreliable, which means that if I were to go out and buy drugs, you know, here in the city I live in, Washington, D.C., or in Baltimore, I wouldn't really be able to know what was in the drugs that I bought or how strong they are. And that is an issue that makes it very difficult for people to use drugs in safer ways. Second, people who have addiction issues need services. They need services if they're actively using drugs, and they need services if they want to get treatment. But it's very difficult to access those services. So I want to talk a lot about why that is and what can be done about it. Third, there are these moments in people's lives which are incredibly dangerous in terms of putting them at risk for an overdose. One of those moments is leaving a jail or prison. So incarceration itself is a major driver of the overdose epidemic, as is unstable housing and homelessness. I guess I would just like to open it up to you all. So let's open it up on the chat window. And if you would like to share any other thoughts you have about issues or causes or factors that are driving the opioid crisis, I'd love to have a little quick conversation with you about that. And I don't know if any questions have come in. I don't have visibility to that. Are there any? Not yet. Okay. Well, we can also move along. I do see.
So, yeah. So comorbidities like mental health conditions, or veterans came up in the as other issues.
Yeah, thank you for that. Yeah, it's both of those are really great points. So of course we know that the opioid crisis has its roots in a lot of factors in our society that are not well managed. One of them is mental health issues. So a lot of people with substance use issues also have a history of trauma or untreated mental illness. And then of course related to that is also the experience of being a veteran. And we know that in our society, veterans also struggle with a lot of health issues, including mental health and substance use. So thank you for that comment. I see one other comment came in. Great. So there's a question here about what do you think about safe spaces for drug use? And I will just ever so briefly touch on that, but I'd be happy to have more of a conversation about it if we have time. So great. Let's close up the chat for now, and I will solicit your questions again in a moment. Okay, if I can get back to my presentation. So the changing drug supply. So I think I said a little bit about this, but basically what you can see is fentanyl is involved in a lot more of the seizures of drugs that are found on the street, but fentanyl oftentimes mixed with other drugs. So fentanyl mixed with cocaine, fentanyl mixed with methamphetamine. So even people who may not intend to be using opioids end up coming into contact with fentanyl, and that's a real problem. The other thing that I wanted to show you is the issue of illicitly manufactured prescription pills. So some people may be not seeking heroin on the street, but rather trying to buy like OxyContin pills on the street. And some of those pills are actually not being made in a pharmaceutical company factory under safe conditions, but rather are sort of being made illicitly and oftentimes mixed with fentanyl. And that can also drive a lot of the overdoses that we're seeing. So one thing that I focus on a lot in my own research career is on medication treatment. Some people call it medication-assisted treatment. We're actually trying to change the terminology around it and take the word assisted out, because the treatment itself is what manages the addiction. So medications, especially the two so-called opioid agonists, buprenorphine and methadone, are known from many studies to cut overdose risk in half for patients who start those medications. Yet we also know that the majority of patients out there today are not receiving any medications. And if they do receive medications, oftentimes they're not receiving them for long enough time for the medications to be effective. So we see a lot of fragmentation in care. Many communities lack any providers who can offer patients medications. I want to return to that issue. And then finally, there is this issue of stigma. Stigma is so important. You cannot understand substance use in America without understanding stigma, the negative attitudes, the discrimination that people face when they either have a substance use issue or they try to get their substance use issue treated. And there's a lot of stigma against medications themselves, including an idea that they substitute one addiction for another. In fact, they do not substitute one addiction for another. What they do is provide a new way for people to manage the symptoms of craving and the biological symptoms of withdrawal that come along with addiction. It's a very different process. Just to sort of, because I am a very data-oriented person, you can see that methadone maintenance and buprenorphine were shown to just hugely reduce the incidence of mortality several months after people experienced a drug overdose. These are data from Massachusetts. Actually, our research team has produced very similar numbers from Maryland. So this is a very kind of consistent finding in the literature. So regulations and more regulations. I know not the most exciting topic for a Saturday afternoon for some, but very, very important for this issue. So the reality is this: if you want to get treated with methadone, you have to go to one of roughly 2,000 clinics in the United States that are specially licensed as opioid treatment programs. In some places, like in Baltimore, there's relatively good availability of opioid treatment programs, but particularly in our more rural communities, patients cannot get to an opioid treatment program. And if they want that service, they may have to drive very long distances. Usually getting treated with methadone means coming into a clinic every day and waiting in a dispensing line to get that medication. I think I want to plant the seed about what would be the implication of that for COVID-19? Why would this be such a huge concern? And then buprenorphine. Well, buprenorphine is easier to access than methadone. You can actually get it from a doctor's office. But to be able to prescribe buprenorphine, a clinician has to have a special federal license called an X waiver. And we know that only about 4% of all US physicians have this waiver. And so this is also a real bottleneck in the ability of patients to get care. I just wanted to share with you all kind of the headline from a study that our team did in 2019 on accessing buprenorphine treatment. I like this study because we used a kind of an unusual study design called a mystery shopper study, where we basically had our research assistants posing as patients seeking treatment to find out basically what treatment experience is like in the real world settings. Not saying here I am a researcher, but saying, you know, here I am a patient, what can you offer me? What we basically found in this study is that, while the good news was that many prescribers were able to offer patients new appointments, that sometimes was issues related to not being able to actually get the medication at the first visit. So there's a lot of things that sort of we think come from the regulation of the medication itself that make it difficult to get rapid access. So being told you can come in tomorrow, that's great. Being told that you can't get medicine for another week, a little bit more tricky for people who are in withdrawal and may be at very high risk of overdose. So I want to come back to this theme that I mentioned earlier of housing instability and incarceration. So if you look at a segment of people who are homeless or a segment of people involved in the criminal justice system, you will find that most of those folks do have some kind of substance use issue. That, compares to about 1 in 10 people in the general population. And sometimes it's opioids, sometimes it's not opioids, sometimes it's opioids in combination with other drugs. Lacking housing is a risk factor for a few reasons. One of them is just that people end up using drugs in unsafe environments, using them in back alleys, using them in areas where if they overdose, no one may be able to really help them, using them in bathrooms and that kind of thing. And that, lacking housing itself is also a very destabilizing experience and prevent people from achieving recovery. Incarceration, is something that has become very normalized in the United States, but for people with substance use issues, it's also an unbelievably scarring experience. We know that in the period directly after release from jail or prison, risk of overdose increases many-fold beyond what you'd see in the population. Here's some data from Washington State from a study that was done over a decade ago, showing you the risk of overdose among people being released from state detention. And you can see that compared to the dashed line, which is the average in the state, that people leaving prison were in incredibly high risk, especially in that first or second week. So policy solutions. So what can we do to kind of address these three big problems? I already saw one of you alluding to one kind of policy solution called a safe consumption space. And just for those of you who don't know what that means, safe consumption space, it's a concept that exists very widely outside the United States. So you can find them in Canada and Australia and in Europe. They vary a little bit in how they're set up, but basically they are places where people can take previously purchased drugs, so they can't buy their drugs on site, but they can bring their drugs in and basically use drugs under medical supervision. And I think the research on safe consumption spaces very clearly indicates that they do have a role in reducing the number of fatal overdoses, that there is someone there who can address the overdose, that they don't tend to cause a lot of untoward harms to the community, that they usually get set up in places that are already having drug use issues. I don't think that it is the single solution to our opioid crisis, because many people will not go to these spaces. So we need to think about other kinds of options for people to meet them where they're at, or given what their needs are. But I do want to open it up again to the chat to see if anyone else would like to offer some thoughts. Great. So I see 3 open questions, and I'm just gonna address them. So what percentage of users get prescriptions, and what percent illicit purchasing? So this is a good question. So if you take a national population of people with opioid use issues, I'm trying to think about what fraction of them now are using prescription medications versus illicit, and I can't remember that number, so I'll have to get back to you on that. We do know that most people who die now of fatal overdose are using heroin and fentanyl, so that those are typically involved. How does the legalization of cannabis affect the opioid crisis? I have a little bit of a stake in this question. In 2015, our study team published a study that kind of kicked off a debate around this issue, where we showed that there was an association between cannabis legalization and opioid overdose, that it seemed to go down in states that had medical cannabis programs. I think since then, there's been a lot of other corroborating data showing that there's something going on there. It's really, really hard to study this in a rigorous causal way. So even though I have played a role in contributing to this literature, I think that I would say I'm not a strong partisan in that debate anymore. Do insurance companies cover the care? That is also a very fascinating question. So Medicaid is the program I study the most, and Medicaid covers, I would say, probably the plurality, if not the majority, of people with opioid use issues. And all state Medicaid programs do cover these services to some extent, but they vary in whether providers are covered in their network, what services exactly they cover. So there are still a lot of gaps in Medicaid coverage. As for private insurance, we do have mental health parity, which also covers addiction. So that has done a lot of good work in terms of getting more people to have these treatments covered by their insurance companies. But we still see a lot of gaps in how insurance companies respond to this, and a lot of techniques like prior authorization and medical necessity requirements that are keeping privately insured patients out of care. So I think there's a lot more work to be done there. I've got somebody is asking a lot of great questions, but I'm gonna just zip ahead to someone who hasn't asked a question yet. Same question about opioid treatment medications covered by medical insurance, and what if someone's uninsured? So uninsured, I think, is the trickiest issue. There are federal dollars through SAMHSA that go to a block grant program to cover treatment. So in some places, people can get a voucher to get treatment even if they're uninsured, but we know that in states where there's better coverage of insurance, people are much more likely to get treated. Okay, I am going to just hold on these questions in the interest of time, but I really, really appreciate all these fantastic questions, so thank you guys. So just going back to my presentation. Oh. So I talk about policy solutions in 3 big buckets, but I do want to make sure we have a little time to talk about coronavirus too. So harm reduction, which means a lot of things to different people, but basically I think about it as all the ways that we keep people safer if they are using drugs. That includes naloxone, which is an overdose reversal medication, also known as Narcan. So making sure that people have access to naloxone kits. Drug checking, which is a technology that a lot of colleagues at the School of Public Health have been working on. For example, offering people fentanyl test strips so that they can mix their drugs with the test strip to see if fentanyl is present. And overdose prevention efforts, including overdose prevention sites or safe consumption, which we talked about. If people can't access treatment, we need to figure out how to make it easier. And I'll talk about how I think that might be achievable. And then in terms of the issues around homelessness and incarceration, certainly there's a need for more supportive housing models, including Housing First. Providing treatment within criminal justice, which is another issue that my research team has been digging into quite a bit, and offering people pathways out of the criminal justice system. So for example, adjudicating people to community treatment programs instead of arresting them and placing them in jail. So I did allude to these different harm reduction tools. I think at their best, this is one of the lowest barrier ways to get people engaged in healthcare services. So if you go to a good syringe service program, not only are they going to offer you, sterile needles if you want to inject drugs, but also offer you access to things like wound care, to mental health care, to other kinds of services, to vocational supports, to employment assistance and the likes. So I think the idea is try to engage people in an experience that is positive and supportive to them, especially because a lot of people who use drugs get treated very badly by their encounters with doctors and other service providers. Not always, but sometimes. I think these programs are certainly not scaled up enough in many communities or coordinated with other systems. Just to show you a different kind of heat map, this is showing the density of naloxone prescriptions per capita. You can see some parts of the country, like Massachusetts and Maryland, just to pick 2 states, have pretty good saturation of these programs. But in other regions of the country, naloxone availability is pretty spotty still. So I mentioned diversion programs. One model that seems very promising is the law enforcement assisted diversion program in Seattle, and now exists in other places too, basically making police officers a partner in offering people alternatives to arrest. Providing medication treatment in jails and prisons has been a game changer in states like Rhode Island. It's reduced overdose risk by 2/3 in the weeks after release. So you know that is an incredibly difficult and dangerous period. If you start people on medication when they're incarcerated, you can actually do a lot to reduce their overdose risk. And then of course, supportive housing and Housing First programs. Okay, so now we're going to switch gears and we're going to talk about COVID-19 in the context of the opioid crisis. But I did want to sort of walk you all through that background just because I think it's really important to fix your understanding of the challenges before COVID-19 hit. So here are some headlines I just pulled from the news, many others you can find right now. So certainly the news media is aware that something is happening, but I don't think any of us totally understand what that something is. So, as we think about our three big problems, it's useful to think about, well, how does COVID-19 affect each of these challenges? So take the issue of the drug supply. Well, what we're seeing is that heroin and fentanyl sources have actually been disrupted. You might think that that's a good thing by getting drugs off of our street, but it's actually causing people to seek out new and potentially more dangerous sources for drugs. So the actual drugs that people are able to access on the street have become, we understand from anecdotal reports, to be a lot less reliable. And that can make the drug use a lot more dangerous for people who are still using. Being able to access treatment, going to a treatment program. Well, as I mentioned, going to a methadone program, that's a daily experience. How does that work in the context of social distancing? It's really, really hard. I've stopped going to the grocery store. I can't imagine what it's like to go to a methadone program right now. And we are talking about a population that is, generally speaking, not well. So a lot of issues related to cardiovascular health and respiratory health common among people with opioid issues. So really a lot of vulnerability there. And then we think about the issues of instability, whether it's homelessness or incarceration or people's mental health. Well, we know, you probably know from your own lives, I certainly know from my own life, this is a very stressful time we're living through. People are experiencing a lot of stress in their home lives, job loss, certainly increasing the number of people who are going to be homeless. And the issue that I think we all should keep an eye on are the recent outbreaks of COVID-19 in jails and prisons. So I will actually pause there and encourage you all to chat with me about these issues or any thoughts, other thoughts that you have at this time. Let me see if I can get to my chat box. Oh, I think I ended the show. I didn't mean to do that. So let me go back to. Sorry, just getting to my Q&A box, but I see it there. Okay. Any new chats or thoughts? Okay, I'm not seeing any. So I am gonna go ahead and move forward. I see that I'm now at the beginning of my talk again. So let me just zip forward to where I was. I haven't been able to track down the data on this, but I have seen reports that drug overdose deaths are reportedly up in at least 20 states. This is just through, one month of this experience, because these data are a little bit lagged. So that is a very, very troubling sign of what we may be seeing ahead. Not opioids, but we know that alcohol sales are substantially up. More people are saying that they're using drugs and alcohol to cope. So in one recent study, a quarter of all respondents said that they were using drugs or alcohol more frequently to cope. And of course, we know just the economic situation that we're all confronting right now. Unemployment having its greatest jump basically of all time, according to what I saw in the month of April, and that just seeming to increase. So our economic situation leading to a lot of people being out of work. That's gonna be a lot of hardship for people. It's gonna lead to a lot of difficulty for folks. COVID outbreaks in jails and prisons. So this is some data that a group at Harvard has put out. Actually, a team at Hopkins that I'm involved with has been involved in a similar effort to track COVID in correctional facilities. You can see that it's been rising not only among staff, but precipitously among inmates. And the slope of this curve is certainly very troubling. We don't seem to see any real flattening in jails and prisons, even as some of these jails have undergone efforts to try to reduce their incarcerated populations. So, to the extent that the opioid crisis really is a crisis that involves many people who are incarcerated, I think that, we really have to keep an eye on this one. So I guess I would like to pause there and just sort of see again whether any of you all have thoughts you want to share in the Q&A box.
There are a few questions, new questions.
Great. So I see one question: what kind of at-home treatments are available? That is such a great question. I'm going to try to talk about this in the next segment, but just to sort of preview, a lot of what we've seen that has been encouraging is efforts to try to allow people to take more methadone and buprenorphine at home. So giving them the medications that they need. You know, other things that are happening, which are kind of interesting, are, you know, telehealth. So meeting with your doctor from your home, and also 12-step groups and other mutual aid groups being provided through online platforms. That's certainly going to work for some people, not everybody. Some folks don't really have great phone or internet access, but at least it provides one new avenue for people to get some help right now. Up-to-date numbers on drug use correlated with COVID infections. That is a terrific question. We are trying to sift through some data right now to figure that out, in particular to understand how much more COVID-19 is burdening people with substance use issues. We actually don't know the answer to that question yet. It's a very difficult population to study under normal conditions. I think what we really want to understand is how it's affecting folks now. And to make matters worse, a lot of the symptoms that are common for being in drug withdrawal are also flu-like symptoms. So some folks may not even know whether they're experiencing COVID-19 versus being in drug withdrawal. So we are seeing some reports of that. You know, in terms of an opportunity, so one person asked about the problem of disrupting the black market and danger for people to get other drugs, but the social impact cannot be controlled without addressing the black market. Is this an opportunity? I think it's an opportunity to the extent that we provide people with an off-ramp. So it's a necessary condition to get people to not get drugs in the black market, but it's not sufficient. People who have addiction issues are going to keep seeking drugs because it really oftentimes is a matter of feeling sick or not feeling very, very sick. So if we don't provide people with ways to get into treatment right now, then we are missing that opportunity. And that is kind of anticipating a point I want to make in the next segment. I guess this person is a clinician who says, I've been providing more anti-anxiety medications in my practice, including medical marijuana, but not more requests for narcotics. So, you know, I think that this is an issue that often gets a little tangled up in how we talk about it, but the use of narcotics as pain relief, certainly, you know, my own position on this is that they are an important piece of clinical practice. They're probably prescribed too commonly. Some patients really do need them, and there's a segment of patients out there that have been chronically dependent on narcotic medications, and we need to figure out how to help those patients. But in terms of, you know, narcotics as a mental health treatment, not a good choice. Let's see. Is there a plan or effort beginning to address the crisis in prisons? I think the answer is it really, really depends on the prison. So we're seeing some baby steps, not at all commensurate with the size of the outbreak, but certainly in some facilities, just an effort to get testing in place so that they even know where outbreaks are happening in the facilities, trying to provide more isolation for patients who are symptomatic, and trying to provide more protective gear for staff. And then finally, there's the issue of trying to provide more compassionate release for inmates. And that is going on, but again, not nearly at the scale that it would be required to stop these full-scale outbreaks that we've seen at places like Rikers Island in New York City. Have there been observed cases when drug users were affected more severely by COVID-19? Like how people with underlying medical conditions are at a higher risk? Yeah, so that I think the question is a fantastic one, and we don't really know the answer to that yet. We do know that people with opioid use disorder are often people who have respiratory issues. A drug overdose itself is a form of a respiratory depression that happens to people. So people can be very compromised in their pulmonary function and in their cardiovascular health. So every reason to suspect this is going to be an issue, but we don't have great data yet. Okay, well, this has been great, and please keep these questions and thoughts coming. I so appreciate it. Otherwise, I'm just speaking into the abyss. Great, so I'm gonna get back to my presentation. Okay. So I kind of alluded to this, but there's been, we talked about regulations and more regulations. Well, actually, to their credit, the Drug Enforcement Agency and the Substance Abuse and Mental Health Services Administration, two federal agencies that are most involved in regulating methadone and buprenorphine, have put in place some recent policy guidance that allow states to basically enable opioid treatment programs to give up to a month of take-home methadone. So patients just have to go to their program once instead of every day, and they can take that medication. Of course, there's a risk that when you dispense that much controlled medication, that those patients will be at risk of overdose. Some of my colleagues in Hopkins Medicine have come up with some interesting partnerships with companies that, for example, have timed lock boxes so that the medication becomes available once per day for patients. That could be a really promising innovation. And then for buprenorphine, there's more chances now to use telehealth to either start patients on that medicine or to continue their medication treatment, and also to allow practitioners to write for longer periods of time. So many of us have been saying, we have to make methadone and buprenorphine easier to access than the drugs on the street are. And I think that these steps, while we certainly have to be careful that they are done in a way where there's still some oversight, I think these are steps in the right direction. Of course, if you read the news, you know that our public safety net programs, which are very different kinds of programs offering different services, are stretched to the max right now. What we do know is that many people are going to be turning to programs like Medicaid and the health insurance exchanges created by the Affordable Care Act. The good news is that we do have a Medicaid expansion program to pick up people who are below or near the poverty line in many states, and that those Medicaid expansion programs do comprehensively cover drug treatment. That's still a bummer in the 14 states that don't have Medicaid expansion. So I think that we're going to still see some efforts to provide some temporary emergency Medicaid coverage in those states. But I truly do not believe that will be as good as the Medicaid expansion coverage. And we've also seen some new flexibility coming from the Federal Centers for Medicaid and Medicare Services in terms of allowing states to seek new pathways to make enrolling in public insurance a little easier. So I think the key here is, if we want people to get these services, we got to figure out how to pay for them. When people are losing their jobs, when they're just worrying about where their next meal is going to come from, we can't really expect people to dip into their own pockets to pay for drug treatment right now. So this is a critical moment for our public safety net programs. The other area where I see some opportunity is around community health outreach. So I think a lot of the innovations themselves are coming from scrappy providers on the ground, trying to figure out how to help their folks during this incredibly difficult situation. A lot more effort to try to provide temporary, at least, housing for folks, but putting homeless people in hotels or other spaces, what have you, at least making sure that they have access to hygienic supplies and to safe housing. Trying to provide people with regular check-ins and providing them with other basic needs like food. In the harm reduction space, a lot of programs have now taken to delivering supplies to people at their homes, including sterile syringes. It's actually an option that is available in many places, but now they're actually starting to take advantage of that. I tend to think that that's a really good idea. Courier services being used to deliver methadone to people in their homes. It's a really different world out there. I don't know how much of this is going to stick around with us, but at least for now, I see these as little pockets of innovation that could be leveraged. So I'm actually coming down the home stretch, so yay for me for time management, but I did want to I did want to open it up again for any thoughts, because I feel like I've just covered a lot of ideas, and I'd be really curious to hear from you all. So again, I'm gonna open up Q&A. Any new questions? So the question came through, what do sterile syringes have to do with treatment? Doesn't that enable users? I think that is a very common starting point. And honestly, it took me a while to come around to the idea that sterile syringes have anything to do with treatment. I am now proudly someone who waves the banner of harm reduction, because from what I can see in the data, a lot of the ways that people get involved with treatment is by getting them into contact with service providers who are meeting their needs. So we got to keep people alive. That's goal number one, keep people from overdosing and dying. And then once we kind of keep people in a position where they're harming themselves less, where they're less likely to get infected with HIV or Hep C, where they're not having active abscesses and wounds, then we can start working on their other needs. And a lot of folks, it's not an either or. Some people, it's not that they want to continue to actively use drugs, they just need that extra little push. So so I think that's where I come down on that issue, but I really do appreciate that question. So a question came through, what are your thoughts on mindfulness practice for treating addictions and alleviating symptoms? And one thing that I should have said at the outset of this talk is that I am not a medical doctor or a mental health professional. So I want to be careful not to sort of overstep the bounds of my own expertise. I'm a policy researcher. Having said that, my own opinion from what I can kind of glean from colleagues is that there is a lot of promising evidence from the research literature about the value of mindfulness practice, either on its own or being integrated with other kinds of treatment techniques. So I think that that's a great component of holistic care. So thanks for that question. The question came in, what does the landscape for Baltimore look like in the near future, given its challenging history of pockets of poverty, drug use, and health disparities in this crisis? Well, I mean, I think that there's some different ways we could look at this. I think one way to think about it is that coronavirus has proven to be extremely adept at coming in and magnifying all the health disparities that we had there the whole time. We know that coronavirus is a profound risk to the lives of African Americans. From what we can see, African Americans have something on the order of a threefold disproportionate risk of dying from COVID-19. So Baltimore really concerns me relative to the rest of Maryland, just because of the social conditions and poverty being exacerbated. On the other hand, I think Baltimore has been living through a lot of the challenges that the rest of the country is going to start experiencing in the context of COVID-19. Whether it's long-term job loss, whether it's food insecurity and things like that. So we all, there's a kind of a tendency to see all the bad in Baltimore. I think since coming to Hopkins, I've come to see a lot of the opportunities to have Baltimore be an example for other places. So the programs that are really working and successful in Baltimore should be carefully watched by other places. And certainly in drug treatment, we've got some amazing treatment providers in Baltimore. Okay, well, thank you for these really wonderful questions. Getting back to my talk. So I think we're at a sliding doors moment. I will, in full disclosure, I've never actually seen this movie. My wife says it's terrific. What I understand is that Gwyneth Paltrow kind of has two possible futures. And the movie plays out and you kind of see how it could go. If she just missed the train or caught the train. I think we're at that moment where the doors are opening in front of us. So I see two futures ahead. I think one possible future is one of a lot of despair. So we're facing not just a recession, but an economic depression. I think what we would expect to see based on research from our last major recession, the Great Recession of 2007 to 2010, was massive increases in addiction and suicide and other related harms. COVID-19 is going to continue to be a condition that I think will plague the homeless, the incarcerated, people who are medically vulnerable, certainly people with substance use issues. The new kind of promising regulations that I talked about that are allowing drug treatment providers to offer more medication treatment, there's no reason to think that those will be continued. So those could be reversed just if the federal agencies decide that, there's no longer a need for them. And I also expect that there could be a lot of cuts made to safety net programs and to harm reduction programs. And all of those things taken together could be really devastating for people with substance use issues. So possible future number one, not so good. And I tried to find some clip art of someone who's kind of a public health dreamer. So call me a dreamer, but I hope I'm not the only one. So possible future number two, I think that we could avert a full-scale economic disaster. I'm not an economist, so I don't know what's really realistic at this point. I think it's possible that COVID will be, contained and we'll get to a vaccine soon. I don't necessarily believe people who say that we're going to get to one in the next few months, but we can dream. We realize that actually changing some of these regulations and providing more flexibility is a good thing overall, and that some of that flexibility is continued and provides more entry points to treatment for people who need them. And my big bold dream is that the public starts demanding greater investments in public health prevention strategies. That we really realize once we get out of this, prevention is a key way to not only keep us healthier, but also keep us more prosperous in all facets. So what's it going to be? So that concludes the formal part of my presentation. I'd now like to open it up for your thoughts and comments, and I can fill a little time if you don't have too many, but hopefully some of you will offer some more questions. While we're waiting for your comments and questions to trickle in, I thought maybe it would be useful to sort of reflect on how public health researchers are going to study this issue. Sometimes people are curious about, how do researchers even try to understand these complex issues? There's a couple questions that came in, so I will come to that, but let me take these questions. So Jaconda writes, I'm from Baltimore, African American, and a JHU grad 2 times over. Awesome. A bachelor's degree and an MS in biotech. I strongly encourage people to read Not in My Neighborhood, How Bigotry Shaped a Great American City by Antero Piatilla. Also, The Immortal Life of Henrietta Lacks by Rebecca Skloot. So I've read the second book and totally second that recommendation. I've not read the first, and I'm very excited to read that. So thank you for those book recommendations. And then Alexandra asks, so let's talk prevention. What are the earliest interventions to prevent people from starting to take drugs in the first place? That is a really great question. So I am a product of the DARE program, a drug abuse resistance education program that was part of the Just Say No kind of movement of the 1980s. I can tell you that program did not work. But there are some other models that are actually a lot more effective at helping children to understand how to navigate whether it's the skill of saying no or refusing drugs, or understanding in a more scientific way what drugs do to the body. There are some good curricula out there. There's programs that work on self-control, something called the Good Behavior Game, which a lot of Hopkins colleagues have worked on. Very effective strategy for creating more drug prevention among kids. And then drug prevention I see as sort of a continuum across the lifespan. So drug prevention can also be about preventing people from escalating from kind of casual or medically indicated opioid use to illicit drug use. And there's some good models there also for trying to help folks. So I will, hopefully you'll indulge me with a few thoughts. I think that it's important to have public health kind of arm in arm with policymakers during this difficult moment. We are trying to do research in real time on this phenomenal challenge. A lot of it will be very difficult to kind of discern cause and effect after the data are all collected. But certainly at Hopkins, I and some colleagues are in the process of launching a study to interview people who are clients of harm reduction and treatment programs to understand how they're experiencing their situation, and also to talk with their treatment providers. So we're in the mode of primary data collection right now and just trying to get out to the field to find these folks and learn more about them. If anyone wants to continue the conversation, which there's a request, please feel free to email me. My email address is publicly available, and it's on my final slide here of the slide deck, which I will get to. So there I am. I welcome hearing from you, and you can also find me on Twitter. Jaconda agrees that DARE did not work, neither did Scared Straight. And adverse childhood events on mental health. Yes, absolutely. We talk a lot about ACEs, adverse childhood exposures or experiences, and we know that ACEs are just much more common among people with substance use issues. As public health professionals and researchers, how are you using data and information from past pandemics and serious public health outbreaks to inform your current work? That is a really great question. This has come up in the context of thinking about issues like outbreaks in prisons. This is not the first time that prisons have had infectious disease outbreaks. So we can know a little bit about what infection control practices worked well in the context of major influenza or other kinds of outbreaks like tuberculosis in prisons, and kind of try to use some of those strategies here. But to be very candid, we've never had a challenge like COVID-19, and there's just so much that we still don't know and understand about it. I think we've got a few more minutes. Any further questions or comments? None at this time. Give it another second. Okay, well, I truly appreciate everyone's time and attention on a Saturday. It's been fun to join you all virtually, and I look forward to connecting with many of you in the future.
Absolutely. I am sure I speak for everyone when I say thank you so much for sharing your expertise and knowledge today. As somebody who works with alumni from public health, I am blown away. Every time I hear one of these, I learn something, and it gives me just such an incredible overview of what we're living right now and the importance of public health today. So it has certainly been a pleasure. So at this point, we wish everyone continued safety and health, and certainly appreciate you joining us for this event, and hope you are joining other events for Johns Hopkins Reunion Weekend Goes Virtual. So thank you so much, and have a great rest of the weekend.